Hello, everyone. This is Glenn Krauss from Core CDI with another great, and I'm prejudiced, of course, and biased, great clinical documentation revolution, protecting clinical integrity and preventing denials. And today we have a follow-up from our previous podcast. We spoke about who owns clinical documentation and the future of CDI belongs to CMO, not the CFO. So we wanted to talk a little bit today about why CDI failed just briefly. I know we touched base last time. Then we want to discuss why physicians must be held accountable. And this third thing is we want to close with the role of the CMO and the physician advisor. And Dr. Pesek, you're a physician advisor. Great. This is a great, you have some great thoughts. Okay. So I wanted to really go over, let's see. Why has CDI, I guess maybe failed is too harsh a word. Maybe you say, why is CDI in effect? Why? Okay, you have a CDI program at your facility. I'm working with a CDI program. I've been doing this for 32 years. Uh, what are the limitations of current CDI? Just briefly, as we segue into how do we hold physicians accountable? How does the CM hold physicians accountable? Your thoughts?
Well, I think Dr. Limjoco will agree with this, but I think the number one thing is communication. To be held accountable to that note. I like to show a picture of the Chicago Bears. I don't
Uh,
hold the picture, so I don't use it very often, but picture a team. Anything that the physician or the consulting services are treating, evaluating, assessing, or monitoring, the physician, the attending in charge, in my opinion, should be telling us this is sort of the narrative of what they're doing. They look at the labs, they examine the patients, they look at the imaging, they consult with the consultants. This is their opportunity, in my opinion, to show us what they're thinking on the paper.
that's right.
And when the CDI is looking, often they're using AI enhanced
That's
uh,
right.
use. AI is not a physician or a CDI or a nurse. It might trigger something that is not clinically relevant. For example, we had one where there was a hematoma noted on the x ray. The attending did not mention it, so we can't really talk about it. But then coding wanted to query when a CDI saw it, whatever came up in the software, and said
Yeah.
there was no drop in the hemoglobin. The physician never commented on it.
Yep.
There's nothing about any loss of consciousness with a mental status change. It just didn't seem to be relevant. But then the coders want to put it in, and then the CMO and the other C-suite. Now we've got a potential conflict and maybe even a metric that is looking like we have a safety issue. So I think the physician really has to realize that in 2026 and on, that the documentation has to be very detailed and very complete. And they're the ones that are the keepers of that. And if they don't do that, they could be getting things like queries. And if they're not careful in the way they answer them, then they will be held accountable, not only to the patient and the patient's loved ones to whom they
Yeah.
are accountable, and
Right.
to the hospital, but possibly in a legal sense. And I would hate to see somebody dragged into something because they didn't take the time to appropriately communicate the situation.
Uh, Dr. Lemhoko, what are your thoughts briefly?
What Dr. Pesek actually described is what I would call automation bias. When your tools, which includes AI, has been learning or has been taught the data from the past, from historical data, and historical data has been focused on capturing diagnosis, capturing CCs and MCCs. And that's what it's going to do because that's what it's learned on. Is AI, in effect, is going to scale whatever the issues that you had before and scale it exponentially. So you'll have more problems if you do it that way. And I think it goes back to my second point is again governance. Whatever tool you have, or even if you don't have any tool, your mindset, your why, as we talked about again and again, should be based on what's true, on what's best for the patient, and not everything else comes secondary.
That's right.
Financial considerations, quality considerations, medical legal issues, those are downstream effects of what you've put down in the record of what the clinical truth is.
And that's the most important. And I just want to, before we jump to our next discussion here, you said automated, what do you call it? Automated
Autom-
bias.
Automation bias.
Yeah, automation complacency. The doctor gets something put in front of him that he didn't suggest, he didn't think about it, he didn't synthesize the information. He's going to automatically say, okay, it must be right. Consciously say, not because he wants to be wrong. It's okay. He or she said, oh, a query is put in here from an AI tool. I'm going to check off the first thing on the list because I know that's
Can I
exactly what they're asking for. Go
can I
ahead,
add just
Lim.
one more thing? The other problem I think we all understand is that in this environment that we're actually working with, which is fee for service, it's volume driven.
That's
And
right.
because it's volume driven, you just think about a physician who has to go through about 25, 27 cases a day. It's almost impossible for you to get your critical thinking down on being recorded. It's hard. And we really have to think about that and make sure that we put importance on clinical documentations so that that is figured into what the daily task, the daily schedule of a physician is.
And speaking of volume, my experience working with different consulting companies, hospitalist companies, is there's one that I work with uh, uh, that truly believes the sweet spot for being able to communicate and chart effectively is 15 to 17 patients a day. When you get to 18 or 19 or 20, or 21, 22, I see it. I see the quality of documentation go down, go to detract very, or become much, much less effective. This leads me to my next discussion point. How do how do we hold physicians accountable? Okay, in other words, uh, what is the role of CMO in conjunction with the physician advisor? How do we how do we hold physicians accountable? Because I always get this situation of, well, I got 20 patients, or I don't have time for be more complete. And my response to physicians is, when you signed up to be a physician, you agreed to provide quality care. Quality care stems from quality documentation. Your thoughts, Dr. Pest, starting out?
Well, I agree that the buck stops with the physician.
Hmm.
I think a good CMO will know what the rules and regulations and bylaws of their hospital include. I know some
Okay.
don't allow copy, paste, and clone. I know some want everyone discharged by 11. Um, and, some of those good intentioned ideas can backfire then if they don't get them discharged. So, then do you want 80% of them discharged by 11? There are ways of doing it. One thing that I have seen done successfully is the idea of a scribe, whether it is a AI tool, and you get everybody's permission. We've
Yep.
seen that where that hasn't gone so well. Or you actually have a person who is that living scribe. Uh, I've seen that done where someone will take on, say, a chief of staff role, and they're still having 20 patients on their list, giving them that scribe to be supported
Oh,
financially,
yeah.
that gives them more time. I think that would be an interesting study if hospitals looked at some of the AI tools. I know some hospitals are using that, and it's going very well. The physician has to go back and make certain that everything is the way that it should be, that they want it, so there isn't some confusion. But compare the richness of a note when you're there in the heat of the moment with the patient and maybe whatever family members that the patient wants involved or loved ones. And then compare that to 10 o'clock at night. The only thing that's standing between you and finally going to bed is finishing all these daily progress notes. The quality, I think, is definitely going to suffer
It
in
is.
the latter, and you won't get the richness. Don't tell me that they have heart failure and you're continuing Lasix. Tell me more about the heart failure. Wrap in the exams
That's
and
right.
findings and lab findings and imaging, and tell me what the plan is. What's the goal? Are we continuing IV Lasix to a certain net volume? Are we transitioning over to oral? Are we starting Diamox or some other agent to assist? If there's a way that the CMO could get those metrics and determine, talking to their medical staff, what is the best step. Patients aren't going to go away. Hospitals want the patients to be there, but without the appropriate and complete documentation, as doctor would say, the clinical truth, you're not getting the whole story. And then that sets the whole CDI coding.
That's right. That's right. And one thing I want to add is that is if the story's not there, UR can't do their job appropriately. Uh, the case management can't plan for discharge if you don't know what the plan of care is. You have CDI focusing on diagnosis, but there's no clinical story, or the clinical story as like you like to use done diagnosis evidence by severity, cause and effect, treatment and monitoring. If physicians would follow that in every diagnosis that's acute, they would not get, they wouldn't get half the queries. If you ask physicians, what is your biggest, hey, doctor, what do you think of queries? You're going to get an earful. How would you like to alleviate more than 50%? They pay attention. I don't want 20 queries. I see sometimes, Dr. Limjoco, a case with 4 queries. If I was a doctor, I'd be screaming. 4 queries on the same case. That's because the documentation wasn't there to begin with. So you got to have the story. Dr. Limjoco, anything to add to Dr. Pesek's excellent discussion before we kind of wrap up with the last question?
Well, I wanted to add something to what you said and about capturing diagnosis and putting out queries out there.
Yep.
That is really what you're describing is that of an extraction philosophy. You're extracting diagnosis, CCs and MCCs,
Manufacturing.
and as opposed to integrating narrative integration, you need to make sure that there is transparency in the narrative to make sure that the why is adequately accounted for
Mhm.
in the documentation.
Yeah, why did I arrive at this diagnosis? How does the diagnosis be supported by the clinical facts indicators, information that's available that the doctor synthesized but didn't tell us, but should tell us? And how does a diagnosis impact the management of the patient throughout the stay? Those are 3 key points the doctor's doing in there, right up here, right? They can do it in their sleep. They got 10 years of training. Some of them been practicing for 12, 15, 20 years. They just don't communicate it in the chart. Then it starts a whole process of a query. You are asking, why is the patient inpatient? Quality asking, why didn't you document this? Trying to hide things under the rug. It's just a mess, right? It's just, and it all goes back to one solution: better documentation, right? Uh, Not copy and paste. So I want to close with this. Okay. What are your thoughts, Dr. Pesek? You're a physician advisor with years of experience. How can the physician advisor help the CMO in getting and pointing the CDI in the right place towards 2.0, which put on LinkedIn several times. Okay, and you've commented on it. And how do we point the physicians in the right direction of saying it's not an afterthought, it's integral to the practice of medicine?
Yes, I think it starts with information. The physician advisor needs to know what the top diagnoses are that are denied, whether it's from a standpoint, CDI downgrade, case management having problems with placement, understanding what is it about those diagnoses? Is it because it's not as complete? Are we saying failure to thrive when we really should be
Oh,
saying encephalopathy or something? And then speaking with the CMO and also getting the CDI team on board and saying, I'm going to go educate, pick a topic. Recently, there was a heart failure article, went to the cardiology team, made sure they were on board and spreading the message to the hospitalists, trying to get CDI and coding on board. It's a little hard because their language doesn't quite match up yet. I'm sure it will soon, but trying to get everybody on board. I think as much as the CMO is a bridge between the C-suite and the hospital staff, the physician advisor needs to be a bridge between the C-suite and the physicians and CDI and
oh,
and
absolutely.
quality. I don't think anybody's trying to sweep something under the rug. I think they're just trying to make certain that they are appropriately documenting something. If somebody has a history of spontaneous pneumothorax problems and happens to have one in a post-operative period, but
Mhm.
it's not due to the surgical procedure, we need to make sure that our physicians aren't or non-physician providers aren't documenting it as post-operative whatever.
Yeah,
Yes.
and I and
So I think
I
that's a
wanted to
good
clear.
way to help your CMO, help your
Mhm.
chief quality officer if you have one. I think everybody wins. And again, you're telling the true story of the patient and not going off on some extraction mission to just.
I like that extraction, don't you, Dr. Peskin? That's a
Yes,
good.
I do
Oh,
very much.
but that sounds even more appetizing than manufacturing diagnoses, uh, which I've been. And I wanted to clarify before I asked Dr. Limjoco to close. Uh, uh, that I don't necessarily mean to sweeping under the rug, but I oftentimes see quality. Okay, we have a ding with a quality measure. We want to go back after the fact and ask the doctor to fix their documentation. Uh,
Well, I
fix
think what it is making the physician aware. They
yeah,
don't know the PSIs,
no,
90 whatever. They don't necessarily know. They may not appreciate some of the exclusion criteria. So it's really going back and asking the right questions.
questions,
So,
right?
doctor, this recurrent spontaneous pneumo, was it related to the procedure in any way other than just a temporal way, the
That's
timing
right.
of it?
That's
And
right.
once, and again, I tell them I'm Switzerland, I'm neutral. I don't want them to change their answer. I
Nope.
just want them to be aware that others are looking at this and to be very, very thoughtful in precisely what they are saying.
And yeah, you hit the nail on the head. The doctor does it. I don't expect the doctor to know all the rules.
Right.
It's challenging enough for them to understand the rules of documentation. So if they follow that, I'm happy. Dr. Limhoko, closing remarks. What are your thoughts?
I wanted to say that all of the things that Dr. Pesek had just described, um, it all boils down to one thing, and that is about showing, really being transparent about what's going on with the patient, the pathophysiology. Because all of those things, the PSIs, the medical necessity, the medical legal issues, all comes down to what's really going on with the patient, what's really happening with that patient. And if when physicians are actually taught that that's what's needed of them, it's not because you said post-op respiratory failure. It's actually getting to the pathophysiology of what's happening with the patient. That answers all of the problems, the issues that are out there. I think it's very important to say that financial outcomes, financial discipline should never mean compromising appropriate care. I'd like to
Well,
end with that.
absolutely. So, Dr. Pesek and Dr. Limhoko, thanks once again for this great discussion. Uh, I think there's like 3 or 4 that are posted to the core-cdi website .com. And I'm going to be posting a lot of resources that I just created over the last few months to the website. So please go ahead and sign up for the newsletter. Then you can go download the material. It's not an infomercial. I'm not trying to sell anything. I'm just trying to share my passion for helping physicians do the right thing. Great quality care, supported by the quality documentation. And I want to thank you once again for your time. Everyone, keep up the great job. Remember, it's clinical documentation revolution. It's a revolution. It's a movement. Okay. Thank you, everyone. Have a great day.